Hey, future Canadian doctors. Getting ready for the MCCQE.
It can feel overwhelming,
Absolutely.
but we're here to help make it a little less daunting.
That's right. We're Harvey and Donna.
And we've been reviewing these MCCQE exams for years
We really want to help students like you feel more comfortable
with the material,
with the process.
with the whole thing.
Yeah, think of us as your guides through some of these key concepts.
To get those aha moments and practical insights,
And we'll be using reliable resources.
especially stat pearls to break things down.
Exactly. And before we get started,
Just a quick reminder,
of course,
this is for informational purposes only.
it is not medical advice.
Always consult a qualified healthcare provider for diagnosis and treatment.
Okay, ready to tackle a topic that we know is going to be on the exam.
Oh, yeah. Let's talk chest pain.
Ooh, chest pain. One of those presentations that can really get your heart racing.
Figuratively and literally. It's the second most common reason people go to the ER.
Oh, wow.
So you really got to know how to approach it.
For the MCCQE, but also
Future practice.
it's real life.
Yeah.
So what makes chest pain so challenging?
It's a bit of a chameleon.
Okay.
So many different causes.
Right.
Presence in so many different ways.
It's like a puzzle where the pieces are always changing.
Exactly.
I bet even experienced doctors find it tough sometimes.
You'd be surprised even seasoned clinicians can get tripped up by chest pain.
Really?
Oh, yeah. That's why having a systematic approach is so important.
All right, let's start breaking it down then. Our Stat Pearls source dives into the different types of pain. Can you explain visceral versus somatic pain?
Imagine you have a stomach ache.
Yeah.
That deep, crampy pain, that's visceral pain from your organs,
Okay.
often described as a dull ache or pressure or squeezing.
Hard to pinpoint.
Hard to pinpoint.
So if someone's having a heart attack
Yeah,
and feels that crushing chest pain,
that's visceral pain.
that is.
And what's interesting is that it can radiate.
Okay.
So that heart attack pain might not just stay in the chest,
It can go other places.
to the shoulders, jaw down the arms.
Wow, that is so important.
It is.
We can't just focus on where they're pointing,
No, you got to look deeper.
right?
Now, somatic pain is different. Think about stubbing your toe.
Ow.
That sharp, intense pain. That's somatic pain from your skin muscles or bones.
Okay,
Much easier to pinpoint.
makes sense.
Specific to the area.
So if I pulled a muscle in my chest lifting weights,
That would be somatic.
that's not going to radiate.
Not usually.
Got it. So understanding these two types of pain, visceral and somatic, that's like step one in figuring this all out.
Absolutely. It's fundamental for diagnosis
And for the MCCQE.
and for those MCCQE questions.
Okay, so let's say a patient comes in with chest pain. What are the absolute first things we need to think about?
First priority, ruling out life-threatening causes.
Okay.
We got to act fast because time is of the essence here.
Okay, so let's talk about those life-threatening causes. What are the big ones?
One that should always be top of mind, acute coronary syndrome or ACS.
Okay, ACS, that's the one that includes heart attacks.
You got it. And when we're talking ACS, understanding those risk factors is so important.
Right.
Things like smoking, diabetes, high blood pressure, high cholesterol,
These all increase the chances of a heart attack.
significantly.
So if someone comes in and they have chest pain and they've got a history of smoking and diabetes, our alarm bell should be going off.
Absolutely. You need to be extra cautious in those cases.
Right.
Pay close attention to their symptoms.
What kind of symptoms should really raise a red flag for us?
Well, the classic presentation of a heart attack.
Crushing chest pain,
Yeah, crushing chest pain, shortness of breath, sweating,
Okay.
nausea, vomiting.
but not everyone has the same presentation.
Not at all. So that's why the ECG is so crucial.
It gives us a window into what's happening,
Into the electrical activity of the heart.
and it can show us if they're having a heart attack.
It can reveal those signs.
Okay, so patients describing crushing chest pain, they've got those risk factors like smoking and diabetes, and we're grabbing the ECG. What are we looking for on that ECG?
One of the key findings for a heart attack is ST segment elevation.
ST segment elevation.
It's a sign that a coronary artery is completely blocked.
Okay.
Requires immediate intervention.
So knowing how to read an ECG is super important.
Absolutely. It's a cornerstone of cardiology.
And they're going to ask you about it on the MCCQE.
Oh, for sure.
Okay, so we've got ACS as our first big life-threatening cause of chest pain. What else needs to be on our radar?
While ACS is always top of mind with chest pain, it's not the only dangerous possibility.
Right.
Sometimes the culprit is lurking in the lungs.
You're talking about pulmonary embolism,
DPE.
a blood clot that travels to the lungs.
Okay.
And it can be tricky because it often mimics other conditions, including a heart attack.
So how do we tell the difference between a PE and a heart attack?
Well, the history is key.
Okay.
People with PE often have risk factors, like recent surgery, prolonged immobility, or a history of blood clots.
So if someone just got off a long flight and they're complaining of chest pain and shortness of breath, should we be thinking PE? Okay.
And the pain they describe might be different too.
Oh, so.
It's often pleuritic, meaning it gets worse with deep breaths.
Oh, okay, that makes sense. So history is really important in distinguishing between these two conditions. But what if we're still not sure? What kind of imaging would we need to do to confirm a PE?
The gold standard is a CT pulmonary angiogram, or CTPA.
CTPA.
It lets us visualize those blood vessels in the lungs
Hmm.
and actually see if there's a clot.
Got it. So we've covered ACS and PE. Any other life-threatening causes we need to be prepared for?
Yes, one more that can be particularly frightening, aortic dissection.
Okay, this one sounds scary. What exactly is aortic dissection?
Imagine the aorta, the main artery coming from your heart like a garden hose.
Okay,
In aortic dissection, there's a tear in the inner lining of that hose.
like a leak in the pipe.
Yeah, and blood starts to flow between the layers.
Sounds dangerous.
It can be incredibly dangerous because that tear can weaken the aorta and potentially lead to a rupture.
Wow, okay. So what kind of pain are we looking for with aortic dissection? The classic presentation is sudden, severe tearing or ripping pain,
Oh, wow.
often described as the worst pain they've ever felt.
And I remember you saying it can radiate to the back.
Exactly.
Yeah.
And depending on where the tear is, patients might also have weakness, numbness, or even stroke-like symptoms if blood flow to the brain is compromised.
Wow, that's a lot to take in. It seems like early diagnosis is crucial with aortic dissection. What kind of imaging do we use to confirm it?
CT angiography is our go-to for this one.
Okay.
It lets us visualize the aorta and see if there's a tear.
And once we confirm aortic dissection, what's the treatment?
It depends on the location and severity of the tear.
Okay.
Some can be managed with medications to control blood pressure,
Got it.
but many require surgery to repair the damage.
So those are three serious conditions where every minute counts.
Absolutely.
It really highlights why we never want to take chest pain lightly.
Early recognition and prompt action can make all the difference.
Okay, so we've covered some of the major life-threatening causes of chest pain. But our Stat Pearl source also mentions other conditions that, while not immediately life-threatening, can also cause chest pain.
That's right. We can't get so focused on the scariest possibilities that we overlook the more common, less dramatic causes.
Right. So what are some of those other culprits we need to consider?
Well, pneumonia, for example, can definitely cause chest pain.
Pneumonia. But isn't that a lung infection?
It is. But along with the cough, fever, and chills, pneumonia can also cause chest pain, especially when you breathe deeply.
So it can mimic that pleuritic pain we see with PE.
Exactly. But with pneumonia, we'll often hear crackling sounds when we listen to your lungs with a stethoscope.
Okay.
And the chest x-ray will show patches of inflammation indicating infection in the lungs.
Okay, so the clinical picture and the imaging findings help us distinguish between PE and pneumonia.
Precisely. Now, another common culprit that often gets overlooked is GERD, or gastroesophageal reflux disease.
GERD. That's heartburn, right? I didn't realize that could cause chest pain serious enough to land someone in the ER.
It certainly can.
Wow.
GERD is essentially when stomach acid backs up into the esophagus,
Right.
and that can cause a burning sensation that feels a lot like chest pain, especially after meals or when lying down.
So how do we differentiate between GERD and something more serious like a heart attack?
Again, a thorough history is crucial.
Okay.
We need to ask about those classic GERD symptoms like regurgitation, a sour taste in the mouth, or difficulty swallowing.
And I imagine lifestyle factors play a role too. Like if someone's been indulging in spicy foods or late night snacks, that might point towards GERD.
Exactly. And we might also consider a trial of antacids or other medications that reduce stomach acid to see if that provides relief.
Okay, so pneumonia and GERD are two more conditions to keep in mind when evaluating chest pain.
Yeah.
And then, of course, we can't forget about those good old-fashioned muscle strains.
Right. Sometimes the simplest explanation is the right one. Chest pain can be caused by something as straightforward as a pulled muscle or a strained rib, especially if there's a history of recent trauma or vigorous activity.
So even if a patient comes in describing chest pain, that sounds really scary, it could be something as simple as a pulled muscle.
Absolutely. We always need to keep an open mind and consider all the possibilities.
So it sounds like evaluating chest pain is a bit like being a detective, gathering clues from the history, the physical exam, and the diagnostic tests.
That's a great analogy. And the MCCQE loves to test your ability to think critically and connect the dots.
They're not just going to hand us the diagnosis on a silver platter, are they?
Definitely not. They'll often present scenarios with subtle clues or cases that don't fit the textbook presentation just to see if you can work through the differential and arrive at the most likely diagnosis.
So it's not just about memorizing facts. It's about understanding the connections and being able to apply that knowledge in a real-world setting.
Precisely. And that's what makes this topic both challenging and fascinating. We've covered a lot of ground in this first part, laying the foundation for understanding chest pain.
We've talked about those crucial life-threatening causes, but we've also seen that not all chest pain is an emergency.
Right.
Sometimes the culprit is a bit more benign.
Right. And in the next part, we'll dive even deeper into some of those specific conditions, exploring the key diagnostic and management pearls that'll help you shine on the MCCQE.
Sounds good. We'll see you there. Welcome back to our deep dive into chest pain,
We're picking up right where we left off,
exploring the fascinating world of chest pain.
a topic that we know is going to pop up on your MCCQE.
And remember, as we unravel this complex symptom, we're using evidence-based information from trusted sources like stat pearls to make sense of it all.
Now, in the last part, we laid the groundwork discussing the different types of pain and those crucial life-threatening causes you need to rule out in any chest pain evaluation.
Right. We talked about the importance of a thorough history physical exam and those initial tests, ECG, CXR, and blood work.
And in this part, we're going to delve deeper into some of those specific conditions, highlighting key diagnostic and management pearls that are super relevant for the MCCQE.
Perfect. So let's pick up with acute coronary syndrome, or ACS. We talked about it being one of the most important life-threatening causes of chest pain, but it's a bit of an umbrella term, right?
Absolutely. ACS actually encompasses a range of conditions, including unstable angina and two types of heart attacks, NSTEMI and STEMI.
Okay, lots of acronyms there. Can you break those down for us?
Sure, let's start with angina. Imagine your heart muscle like a car engine. It needs a constant supply of fuel, which in this case is oxygen-rich blood.
Okay, so the blood vessels are like the fuel lines.
Exactly. Now, when those fuel lines become narrowed or blocked, the heart muscle doesn't get enough oxygen, and that's when you feel angina, that classic chest pain.
So angina is like the engine sputtering because it's not getting enough fuel.
Perfect analogy. Now, unstable angina is when that sputtering gets worse, or it happens even when you're resting.
Uh-oh.
It's a warning sign that a heart attack could be on the horizon.
Got it. So unstable angina is like the check engine light flashing, telling you something's seriously wrong.
Exactly. Now let's talk about heart attacks, also known as myocardial infarctions.
Okay.
There are two main types, NSTEMI and STEMI.
Right, and I remember you saying those acronyms refer to patterns on the ECG.
You're right. Both NSTEMI and STEMI involve damage to the heart muscle because of a blocked coronary artery, but they differ in how that blockage looks on the ECG.
Okay, so for STEMI, we see that classic ST segment elevation indicating a complete blockage. What about in STEMI?
And STEMI might show ST depression or T-wave inversions on the ECG, suggesting a partial blockage.
And I imagine that difference is crucial because it determines how quickly we need to act.
Absolutely. For STEMI, it's a race against time. You need to get that artery open as quickly as possible, either with medications or a procedure called percutaneous coronary intervention, or PCI.
PCI, that's one where they thread a catheter through a blood vessel to the blocked artery and use a balloon to open it up, right?
Exactly. And often they'll place a stent, which is like a little scaffold to keep the artery open.
Wow. It's amazing what they could do these days. So STEMI requires rapid intervention. What about in STEMI?
And STEMIs are generally managed a bit more conservatively, often with medications like aspirin antiplatelet drugs, nitroglycerin, and beta blockers.
So medications to thin the blood, reduce the workload on the heart, and hopefully prevent further damage.
Exactly. But depending on the severity and the individual's risk factors, some patients with NSTEMI might still need PCI or coronary artery bypass surgery.
Okay, so lots of different treatment options depending on the specific type of ACS. It really highlights the importance of understanding those ECG patterns.
Absolutely. And you can bet the MCCQE will test your ability to interpret ECGs and choose the appropriate management strategy.
All right, so we've unpacked ACS. Let's move on to another big one, pulmonary embolism, or PE.
Remember, PEs can be tricky because they often mimic other conditions, including ACS.
Right.
But there are some key features that can help us differentiate them.
Like what?
Well, the pain in PE is often described as pleuritic, meaning it worsens with deep breath. Patients might also have shortness of breath, a rapid heart rate, and even cough up blood.
And you mentioned earlier that risk factors for PE include recent surgery, prolonged immobility, and a history of blood clots. So if someone's just gotten off a long flight and they come in with chest pain and shortness of breath, That should raise our suspicion for a PE.
Exactly. It's all about connecting those dots, the risk factors, the symptoms, and the clinical picture.
And to confirm our suspicion, we'd order that CT pulmonary angiogram or CTPA to visualize those blood clots in the pulmonary arteries.
Precisely. And once a PE is confirmed, the mainstay of treatment is anticoagulation or blood thinners.
Okay, so blood thinners to prevent further clotting and help the body dissolve those existing clots.
Right. Now let's shift gears and talk about that other frightening condition, aortic dissection.
Okay, back to the garden hose analogy. In aortic dissection, there's a tear in the lining of the aorta, and blood starts flowing between the layers, potentially weakening the vessel and leading to a rupture.
Exactly. And because of the potential for catastrophic consequences, rapid diagnosis and treatment are absolutely critical.
So what are the red flags we should be looking for?
The classic presentation is sudden severe tearing or ripping pain, often described as the worst pain they've ever felt.
Right.
And this pain can radiate to the back.
And I remember you saying that depending on the location of the tear, patients might also have weakness, numbness, or even stroke-like symptoms if blood flow to the brain is compromised.
That's right. And to confirm our suspicions, we'd rely on CT angiography to visualize the aorta and identify the tear.
And what about treatment? Is it always surgery?
Not always. It depends on the location and severity of the dissection. Some dissections can be managed with medications to control blood pressure and heart rate, but many require surgery to repair the tear.
Okay, so those are the big three, ACSPE and aortic dissection. All very serious conditions where prompt action is essential. But what about those other less dramatic causes of chest pain?
Remember, we can't get so focused on the life-threatening conditions that we overlook the more common, less serious causes.
Let's revisit some of those. We talked about pneumonia, which is a lung infection that can also cause chest pain.
Right, especially when you breathe deeply. And although the pain might mimic that of a PE, there are key differences.
Like the fact that with pneumonia, we might hear crackling sounds when we listen to the lungs and see those telltale patches of inflammation on a chest x-ray.
Exactly. Now let's talk about another common culprit, GERD.
Ah, GRD, that burning sensation in the chest that we often associate with heartburn.
GERD happens when stomach acid backs up into the esophagus. And while we usually think of it as indigestion, it can actually cause chest pain that's intense enough to send someone to the ER.
So how do we know if it's just heartburn or something more serious?
Again, a thorough history is key. We need to ask about those classic GERD symptoms: regurgitation, a sour taste in the mouth, difficulty swallowing.
Right.
And lifestyle factors play a role too. Spicy foods, late-night snacks, and even stress can trigger GERD.
And I imagine a trial of antacids or other medications that reduce stomach acid can help us determine if GERD is the culprit.
Absolutely.
Yeah.
Now, let's not forget about those musculoskeletal causes of chest pain.
Right. Sometimes the simplest explanation is the right one. Chest pain can be caused by something as straightforward as a pulled muscle or a strained rib, especially if there's a history of recent trauma or vigorous activity.
And in these cases, the pain will often worsen with movement or when we palpate the chest wall.
So even if someone comes in describing chest pain, that sounds really scary, it could be something as simple as a pulled muscle.
Exactly. We always need to keep an open mind and consider all the possibilities. And that's a key takeaway for the MCCQE as well.
They're not going to make it easy for us, are they?
Definitely not. They'll often present scenarios with subtle clues or atypical presentations just to see if you can work through the differential and arrive at the most likely diagnosis.
So it's not just about memorizing facts. It's about understanding the connections and being able to apply that knowledge in a real-world setting.
Precisely. And that's what makes this topic both challenging and fascinating. We've covered a lot of ground in this second part, delving deeper into those specific conditions that can cause chest pain.
We've seen that while some causes are life-threatening and require immediate action, others are more benign and manageable with lifestyle modifications or medication.
Right. And in the final part, we'll tie it all together, sharing key takeaways and offering some final tips for tackling chest pain questions on the MCCQE.
Sounds good. We'll see you there. Welcome back to the final part of our deep dive into chest pain.
We've covered a lot of ground
We have,
from those life-threatening causes.
yeah, like aortic dissection,
To the more common culprits.
GERD.
Right.
We've explored the power of a good history and physical.
Really digging into those details.
Yeah, about the pain.
The patient's individual risk factors.
Yeah, and we've talked about those must-know pearls for the MCCQE.
Like ECGs and CT scans.
Now, in this final part, let's bring it all together.
Yeah, let's crystallize those key takeaways.
Give you some practical strategies for those exam questions.
So when you see a chest pain question on the MCCQE,
Yeah.
what's the first thing you think?
Honestly,
Yeah.
I kind of freeze up. I'm like, where do I even begin?
Right.
There are so many possibilities.
Can feel overwhelming.
It does.
That's why having a systematic approach is so important.
Okay.
It's like a roadmap
Okay.
to guide you through the maze.
Breaking it down into steps.
Exactly.
Got it.
Start with the ABCs.
Airway, breathing, circulation.
You gotta make sure the patient is stable
Yeah.
before you even dive into the details.
We can't be figuring out if it's a heart attack if they're not breathing.
Exactly.
Yeah.
Once you've ensured stability, you move on to that history.
Right. Because the patient's story is key.
It is. It holds so many clues.
It's like we're detectives gathering all those details.
Was the pain,
Onset, location, quality, radiation, severity, duration.
alleviating and aggravating factors.
And don't forget those associated symptoms.
Shortness of breath, sweating, nausea, vomiting.
Yeah. Risk factors.
Smoking, diabetes, family history.
Right. All those pieces help us figure out what's most likely,
Exactly. And then you've got the physical exam.
which adds another layer to our investigation.
Right. You're looking for those signs.
That either confirm or contradict our suspicions.
Exactly.
Listening to the heart and lungs.
Feeling for tenderness, abnormal pulsations.
Not just going through the motions.
Be purposeful. Be systematic.
And then we've got our diagnostic tests.
To help us rule out those life-threatening causes.
ECG, CXR, blood work.
And to guide further investigations.
And we can't forget,
Yeah.
the MCCQE is going to try and trick us.
Oh, yeah.
Yeah.
They're not just going to test you on those textbook cases.
Right.
They're going to present you with subtle clues.
Atypical presentation.
To see if you can really think critically.
So we have to understand the nuances
You got to apply your knowledge.
to those real-world scenarios.
Exactly. Where things aren't always clear-cut.
Right. So it's all about practicing that clinical reasoning.
Imagine you're actually seeing this patient. What would you ask?
Right.
What would you look for?
What tests would I order?
Exactly.
Like a mental simulation.
It is.
Okay, so most importantly,
Yeah.
don't panic.
Don't panic.
If you get a tough question,
Take a deep breath.
break it down into those steps.
Use your clinical reasoning skills.
I like it.
All right.
Any final words of wisdom for our listeners before they take on the MCCQE?
You've got this.
Wow.
You've spent years honing your skills.
Right.
You've built a solid foundation of knowledge. Trust yourself. Stay calm.
Be systematic.
Approach each question with a clear mind.
One step at a time.
Exactly.
Believe in ourselves
And remember, the MCCQE is just one step
on a long road.
in your journey to becoming a physician.
That's right.
Focus on the learning, not just the outcome.
Keep learning.
Keep that passion for medicine burning bright.
And don't be afraid to ask for help.
There are so many resources and mentors out there.
So that concludes our deep dive into chest pain.
We hope you feel a little more prepared.
To tackle this cuff topic on the MCCQE.
Best of luck on your journey.
And remember,
We're always here to support you.
until next time, happy studying.